It's always a difficult talk to do, this one, because you've all done anatomy, you've done your operating, so you essentially know what the anatomy is. So what I've thought that I'm going to do today is to throw in some concepts. So that's going to question the way you look at a female pelvis, so that you understand some of the things that we do and some of the things that we could potentially do, and so that it triggers some thinking. So that's the point of doing this talk. Okay. So as I said, I'll talk a bit briefly about the anatomy and some of the concepts which I think are guiding how we manage our cases, and what it means for us as clinicians. So obviously, when we talk about the pelvis, we talk about the bone. There are ligaments, and there are tissue around it, especially the muscles and the connective tissue. So as physiologists or physiotherapists, you would be interested in the muscles. Most of the gynecologists and the functional urologists would be interested in the connective tissue aspect of it, because that's probably what contributes to the supports. So for the next 20-30 minutes, I want you to imagine that you're sat inside the pelvis. Okay, so that's what I want you to think. So when it comes to the bony pelvis, you have got, that's the bony pelvis. Okay, so you've got 3 bones essentially, which would have fused when you're around 18. So you've got the iliac bone, you've got the ischium, and you've got the pubic bone. So they usually fuse around that area. We all know that, yeah. And that is attached to the to your there's 2 on either side. That's attached to your sacrum. So that's what is your pelvis. And these attachments, there are lots of ligaments, as you can see, and it is these ligaments, that some of these ligaments are useful for gynecologists. Some of these ligaments are useful for the orthopedic surgeons and things like that. But it is important that we understand these ligaments. So if you look at that, so that's the anterior longitudinal ligament. That is important to some of us. So it comes, it's all the way along the spine. You've got the sacrospinous ligament there. The sacrotuberous ligament, we don't use it that much, but that's the sacrospinous ligament. And this is the inguinal ligament, and this is the pectineal part of the inguinal ligament. Okay, and when you go back, you've got all these sacrotuberous and the posterior sacroiliac ligaments, which is of use. So basically, if you imagine that's the vagina, if you were to utilize that one, the anterior longitudinal ligament, you are fixing it. If the vagina, if you're in the pelvis, and that's a tent there, and if that is caved in, you need to fix it somewhere. If you're going to fix it to the anterior longitudinal ligament, that becomes your sacrocolpopexy. Okay, there's a lot of confusion. My anesthetist has been working with me for years. She still doesn't understand the operations. Colpo is vagina, and sacro is sacrum. You suspend the colpo to the vagina, it becomes sacrocolpopexy. Okay, you're using a vagina, so that's the point. Okay, you've got the sacrospinous ligament. So if you fix the vagina to the sacrospinous ligament, it becomes a sacrospinous fixation. Okay, so we utilize that, and that's the procedure done through the vagina. And the sacrocolpopexy, you do it laparoscopically or through laparotomy. You've got these 2 ligaments. This is the inguinal ligament fanning off, and that's the pectineal part. If you suspend the front of the vagina to there, that becomes your colposuspension. Colpo is vagina, suspending it is colposuspension. So those are the points that we utilize, from a pelvic surgery point of view, and that's what you're looking at, So you've got a vagina, which is a floppy organ. You fix it there, you fix it there, you fix it onto the side. As simple as that, yeah. So those are the ligaments you need to know. When you turn back, you'll obviously learn about these points tomorrow, where you're going to do your sacral neuromodulation. Okay. So when I think of the pelvis and the pelvic floor, you need to imagine that the abdomen is a tense balloon. Okay. So you've got the diaphragm at the top, you've got the abdominal muscles, you've got the spine and the paraspinal muscles, and you've got the pelvic floor. That's essentially it. The organs are all being, in different, relation to those muscles. Okay. So if I were to look at it from the top, this is how it would look. Okay, so I'm looking at I'm standing there in the roof and I'm looking at the pelvic floor. Okay, so this is the pelvis we said. Okay, so if you were to sit at the top and look down, this is what you're going to look at. Okay, so imagine there are 3 tubes. Okay, so you're looking at it there. There are 3 tubes. There is the urethra, vagina, and the rectum. Okay, so that's there, and that's your pelvic floor. That's what we are talking about. So when people say pelvic floor, this is the pelvic floor. Okay, there is a sheet of muscle that comes behind. Okay, so this is your puborectalis. Okay, so there's a sheet of muscle that comes from the front, goes back behind the rectum, and goes up. So that's your puborectalis, puborectum. Okay, so that's your first part of your levator ani muscle complex. Okay, that's what gives you that if you have seen the rectal junction, that's what gives that angle. Because this muscle is pulling up. All skeletal muscles have got a bit of tension in them. There is a bit of tone to it. So that's why there is a bit of tonic contraction, which is what lifts everything up. And that is connected. Obviously, you've got a median raphe and it goes back. That's the insertion. There's lots of studies about detachments there and detachments there, detachments here. We still don't understand the utility of that information, but that's the first part of a pelvic floor. When you're assessing a pelvic floor, which Jen is going to talk about, your finger is in there. When you ask your patient to elicit a contraction, this is what your patient is doing. That's what you're trying to figure out. You put your finger in, you ask her to contract, she elevates the puborectalis, and that's what is your pelvic floor. That is practically the only muscle that you're going to assess, and you assume that the rest of those muscles are okay. Okay, so when you talk about Oxford contraction, Oxford score, and things like that, you're basically eliciting a contraction, and it's lifting things up. That's as clear as that. Yeah. So that's the first muscle, and you're getting muscles from the side. Okay, so you look at it at the top, and your muscles come from the side. Okay, you've got 2 muscles. One is your iliococcygeus, and the other one is the ischiococcygis, or the coccygeus muscle itself. They're coming from the side. Okay, so those are the 3 parts of your levator ani. As simple as that. Yes. So when you look at it from the top, 3 muscles. One is coming all the way like that. The other one is coming through the sides. So that's what is holding your pelvic floor, or your organs, your uterus, your the vagina itself, the bowel. Everything is being held, like that. Because it's skeletal muscle, it's got tension. It's going to hold things up. It's got a tone to it. Okay. As simple as that. So I've now gone beneath. Okay, I'm going to sit from inside, from sort of down below, and looking at it up. Okay, you've got the levator ani there behind. You're with me with the orientation. Okay, so I'm looking at it from through the perineum. This is a focus of attention. So the perineal body, or the perineum, that's on a sort of grossly, when you inspect, that is from the fourchette, which is your posterior aspect of the vaginal opening or the introitus, and the anal opening. So that area is your perineum, and that's where your perineal body is, and that's the central tendon. That's where all the muscles of the perineum are being attached. And that's the focus of attention. So when childbirth happens, this is where the damage is happening. Okay. And obviously, as you can see, that's what detaches some of the muscles. Okay, so you've got 2 muscles there. You've got the superficial transversus perineum and the deep, which is behind it, coming from both sides. So you've got the central tendon, the muscles coming from either side, from this side, from the front, and that's what is holding. It's a sort of a very important structure to try and balance the pelvic floor. So you've got those 2 muscles coming. When we have episiotomies and when you have 3rd-degree tears, most of the juniors would confuse this for your perineal muscle tears. So that's why you have to put your finger in the rectum to actually figure out whether it's your transversus perineal muscle or is it your external sphincter. You can see your external sphincter. That's the anal sphincter. That also has attachment through the central tendon. Okay, so you've got 4 muscles from the side. You've got the external anal sphincter, which is attached there as well. Then you get muscles from the top. You've got the bulbar spongiosus coming there. You've also got ischiocavernosus, which is obviously more important in men, but it goes to the front. Okay, so those are the muscles. So if you remember the central tendon, you've got all those muscles being inserted. Okay, when you're doing repairs and things like that, it is important that you try and reconstruct it. We don't have any evidence to say whether we should be doing some reconstructions around delivery, but we don't know. Maybe there is an element of that, but we don't have any prospective studies to talk of that. But there is definitely some evidence to say, if this is short, you can have trauma in delivery. That is when women have problems. So the length of this, correlates with the risk of trauma and further pelvic floor dysfunction. Yeah, we're all happy with that muscle orientation. Yeah, so you've seen from the top, you've seen from the bottom. Okay, so when we talk about the orientation, this is some work done from Michigan. Delancey and others have done a lot of work on that. If you look at our traditional view of the pelvis, when I talk to my patients, I would generally say, if you're in the vagina has got a front wall. I tell them, if people live in the UK, we know what a terraced house is. Yeah, there are houses one by side of each other. The vagina and the pelvic floor has got three houses. You've got the rectum next door. There's a wall, vagina, bladder next door. So easy to sort of say. But these evidences, were all from dissection. When you're doing a prosection or dissection, all this muscle have got no tone, and they're all fixed. So the vagina is not a straight organ. So the vagina essentially, when you look, so the pelvis is essentially in this direction. If I was a woman and if I was standing, this is the direction. This is in a horizontal plane. So that's how the pelvis is. Okay. So the vagina would enter at an angle, and then it is almost horizontal. The upper vagina is horizontal. You need to remember that. Okay, it's not a straight organ. Okay, it goes up and it's horizontal. So it basically rests on the pelvic floor. We talked about that. It enters like that, and it is falling back on your pelvic floor. So it is not straight. The vagina is flat. Okay, like that. So that's what you need to remember. That's why your anterior wall is under more tension. You get more recurrences there. Your posterior wall, is pretty much being supported by your pelvic floor. So going up and that. So that's what I want you to think. Okay, that is where our anatomy was wrong, because we were taught like that. So they're not straight compartments. It's essentially an superior and inferior surface of the vagina. So Delancey talked about three levels of supports to the vagina. Okay, so we talked about the vagina going up and like that. There are three levels of support to the vagina, and that's what I want you to understand. Okay, this is some concepts which is not taught in some of the medical schools, but it's really important. Okay, that's the first level, which is the top end of the vagina. Okay, it derives attachment. This is all pelvic condensations. There is no musculature attached to the top end of the vagina, the cervix and the uterus. Okay, so the uterine attachment is essentially on the cervix. The top end of the vagina or the uterus is floppy. Okay, so it can be tilted back, it can be tilted to the front. It varies. Okay, 15% of the times it's back. That's normal for that woman. So it's the cervix which is like the central tendon at the top. Okay, so that's why some surgeons argue that we should be holding on to the cervix and not taking it out, because we can utilize these structures. Okay, so you've got the uterosacals, which is coming from the top, and you've got the McEnroth's ligaments, or the lateral pelvic ligaments, which is holding the vagina. Pelvis, that's the sacrum, that's the pubic symphysis. So there are two ligaments, cord-like ligaments, coming to the cervix like that from the top, and they're holding it like that. So that's your uterosacals. You've got lateral condensations coming, that's your McEnroth's ligament. So that's your level 1 support. Okay, that's Delancey level 1. You can call it by his name. Okay, so if there is a damage there, you get the vault if there is no uterus, or you get a uterine prolapse. Okay, no muscles. Okay, So for a uterine prolapse, if the uterus were to drop down, your pelvic floor physiotherapy is not going to lift it up, if you believe this. Okay, that's the science behind it. Okay. Then you have level 2. Okay, we're coming from the top, we've gone down a bit further. This is your mid vagina. So the mid vagina again has got some, the levators do affect, but they are sort of condensations from the lateral pelvic wall. That is something called as a white line, which is essentially another further condensation which goes that way. So the vagina is being suspended, the horizontal vagina. So the vagina is vertical and transverse in the pelvis. You got horizontal ligaments coming from the sides supporting it. That's your level 2 support. If you have problems there, you get anterior vaginal wall prolapse, the stress incontinence, and that sort of thing. Happy with that? The levator ani is also, pelvic floor physiotherapy will probably help with this one as well, because this is influencing a bit of that support. The bottom end is your urethra, your perineal body, and everything, and that's your musculature. That's your muscular part. And if you have problems there, you've got posterior vaginal wall prolapse, you've got perineal descent, you've got anal prolapse, and things like that. So that's your 3 levels of support. You happy with the Delancey supports? Okay, so this is a concept. This is what we should be knowing. Okay. Okay, so again, going back, that's the vagina. It falls back on the pelvic floor, and that's how it's being supported. Does that make sense? So the vagina, if you're in the pelvis now, sat in the pelvis, the vagina is a floppy structure like that. It is standing like this. Yeah? Happy? You're in Bristol, okay? I don't know whether the Australians like the integral theory, but I have to throw it in, okay? Because the TVT is based on this theory. If you're in Bristol, you're going to have a look at this bridge, yes? Every time you look at this bridge, you're going to think of the pelvic floor or the vagina. So this is a suspension bridge, okay? So basically, you've got 2 columns, and there are ligaments, supporting this structure, okay? So the next time you go on, or if you have an opportunity to go under the bridge, imagine you're walking. You're walking on the vagina, okay? Okay. So that's what you need to think. Thank you. So you're going to think of how this is, related to the vagina, okay? So this is what it is. You can see you got the pubic bone there. That's the sacrum, okay? So that's your 2 pillars, okay? So you're gonna, you probably will end up walking through the pubic bone towards your sacrum, okay? So you're gonna if you go tonight, that's what you're gonna do, yeah? So you've got the vagina there, okay? So the vagina, we said, is a horizontal structure. You're getting supports there. So you've got the uterosacals holding on to things. There are ligaments. That's what it is. In terms of the suspension or the suspensory ligaments. You've got the uterosacals and the Macken-rods. That's the vagina. You've got the white line. Can you see the white line? That's the arcus tendinous fascia pelvis. Okay, and you're getting attachments from the side. Okay, and there are tough structures holding on there. That's your uterosacals. You've got tough structures there. That's the Macken-rods. So your uterus is there, and the cervix is there, and that's the vagina coming there down. And then you've got the suspensory ligaments in the front. Your pubocervical ligaments. Your pubocervical ligaments there. You got the lateral ligaments, uterosacals. That's the vagina. So that's the theory. Okay. Can you see this picture as well? Yeah. Can you see those ligaments? So that's the vagina. That's the suspension bridge. You've got ligaments coming from the front, ligaments coming from the back. So this is the theory that was proposed by Petros, and some of the operations, especially the TVT or the mid-urethral sling, is based on that. There are other operations based on this theory, which a lot of consultants or a lot of colleagues don't do, but it's a concept. That's where I want you to think on those lines. So if you have any damage on that side, you get anterior vaginal wall, urethral, stress incontinence side of things. That's what your TVT is doing. You're trying to mimic this ligament with your TVT. When you're doing a colposuspension, you're trying to mimic those structures, because that part of the bridge is broken down. Okay, your colposuspension is essentially trying to do that. Okay, so if the middle bit breaks down, you've obviously got cystocele, paravaginal repair, and things like that. If this bit breaks down, you get your uterus or your walled prolapse. Okay, whether that's where your hysteropexy is trying to hold on to the cervix and you're lifting it up. Okay, so that's what you're trying to do. When you're doing uterosacral plications or uterosacral walled suspension, you're trying to attach the top end. Does that make sense? Yeah? Okay, so that's the concept. That's called integral theory. Okay, there's lots of work around it. There are free PDF versions. If you just Google it, you will get versions of that. But obviously you need I needed permission to get that in, but you can Google it and you'll get it. Okay, this is again something that I wanted to bring it in terms of urethral supports, because we are dealing with stress incontinence. I thought I should bring it in. This is again some work done by Delancey. This is a female urethra, and when you cough, sneeze, you're squeezing a balloon full of water, and you need the valve to be strong enough. So this is what gives, if this is your urethra, if you divide that 4 centimeter urethra and consider it as 0 to 100, this is where your structures are. Okay, you can see you've got some muscular components, you've got the pelvic floor, you've got ligament supports, all this contributing to the the continence mechanism, the tap mechanism. Does it make sense? Yeah, so just something to be aware of. I thought I should throw it in because of the anatomy side of things, because we'll be dissecting in that area. This is looking at it from the top. I have, imagine we have done a laparotomy at higher level. You strip the peritoneum down, and you're looking at the anti-abdominal wall. Okay, so this is your pelvis. Okay, so you're looking at it like that. Okay, you've got the pubic symphysis there, and you've got the anti-abdominal wall muscles there. Okay, so essentially when you talk about the white line, this is where things will be going in. When you put stitches, you're putting at the level of bladder neck and you're anchoring it there. So that's your colposuspension. Always remember this epigastric vessel. If you dissect too laterally, you're going to injure those structures. Your external iliacs are quite close as well. If you dissect quite laterally, you will have your obturator vessels. So you need to be careful as to how far you dissect, especially if you're doing laparoscopic colposuspension. You would need to be very careful. When you go into that area, it's quite easy to go into those structures. Okay, so just to be mindful of that. Again, we all will deal with at some point women with pain. You need to think of your neuroanatomy as well. So you will have 2 nerves which come in that mons pubis or your suprapubic area, your ilioinguinal and the genitofemoral nerve, and that's where it's coming. I don't think there is any way to predict which way your needle is going to go through when you do a midurethral sling insertion, and potentially this is where your patients are getting pain when they have neuropathic pain. So these are the nerves that you're damaging. When you're doing your obturator insertion of tape, you get this sort of pain on the medial aspect of the thigh, because you've got a cutaneous branch of the obturator nerve coming in. So you need to be mindful of that. You've got the ilioinguinal nerve, you've got the iliohypogastric nerve. These are all the areas where you will get pain. These patients get pain. The likely explanation, if it happens immediately after the operation, is it's probably irritating one of those nerves. Okay, so there are nerves there that you need to think of. You've got the genital branch of the genitofemoral nerve. So the femoral nerve that goes into the femoral canal. You've got the genital branch which crosses and comes on top. You've got the iliohypogastric and the ilioinguinal nerve as well. So those are the nerves that you need to think of. And very likely if you have irritation immediately after the operation, you're probably irritating one of those nerves there. Okay, so be mindful of that anatomical option and concept. Again, you know, if you talk of the operator approach, when you're doing that, you know, your operator vessels are on the other side, you know, so if you go anywhere further than what is needed, you know, that is where you're at risk of injuring your operator nerves and vessels. Okay, just simple, you know, for some of the juniors here. When you talk about the sympathetic and the parasympathetic, most of the structures in our body will have a yin and a yang. Okay, so it's like the balancers of our body, you know, so we'll have parasympathetic and the sympathetics. That's your yin and yang. Okay, so the simple way to remember is parasympathetic helps you to piss, sympathetics help you to store. That's it. There is a balance between that. So when you're treating them, you want, if it is a storage problem, you want to increase storage, you stop pissing, which is anti-parasympathetic, anti-muscarinic. Stop pissing would mean increase storage, so that means increase your sympathetics. You've got a sympathomimetic drug, which is your Betmiga or Mirabegron. So that's a simple way to remember. Okay. The reason I brought it in is this is where, you know, your parasympathetics are. You know, so when you do your sacral dissection, you know, when you do your sacral sacrocolpopexy, you're likely to hit some of those, you know, hypogastриc plexus. You know, so the important thing is the sympathetics will be thoracolumbar, and your parasympathetics is craniosacral. Okay, so it's the sacrum which gives you the parasympathetics, and it's your thoracolumbar which gives you the sympathetics, and that's where the structures are. You know, and there is no way to predict, you know, how to go through this. You know, there are some surgeons, you know, who would deal with these nerve plexus, but it's always, you know, important to remember that try and stay as close to the organ as possible, you know, and that is when you will avoid damage to these structures. Okay, so it's just to give you an idea on that. Okay, so it's just a few concepts. You know, I'm sure, you know, when you dissect, you will know more.